Welcome to the Culture of Healthcare, Quality Measurement and Improvement. This is Lecture B. The component The Culture of Healthcare addresses job expectations in healthcare settings. It discusses how care is organized within a practice setting, privacy laws, and professional and ethical issues encountered in the workplace. The objectives for quality measurement and improvement are to define healthcare quality and the major types of quality measures, structural, process, and outcome measures. Describe the current state of healthcare quality in the United States. Discuss the current healthcare quality measures used in various healthcare settings in the United States, including those required for the High-Tech Meaningful Use Program. Describe the role of information technology in measuring and improving healthcare quality. Describe the results of current healthcare quality efforts in the United States. This lecture will examine quality measures that are currently used, including those required under the Stage 1 Meaningful Use Rules of the Health Information and Technology High-Tech Act. A sampling of current quality programs and measures in use appears on the screen. Berwick has noted that we are early in the science of quality improvement. What exactly is that science? There is an Institute of Medicine report that describes the science behind healthcare quality assessment. Many measures have been developed, all reflecting different perspectives, somewhat like standards. AHRQ maintains a clearinghouse of the different types of measures that are available, where they are being used, and so forth. But there is clearly a growing consensus that we need to develop standardized sets so that we can implement them in standardized ways and obtain value from them. In the following slides, we will talk about specific quality measures from different perspectives: the perspective of health plans, the perspective of outpatient medicine, the perspective of inpatient medicine, and those required under the Stage 1 Meaningful Use Rules of the High-Tech Act. The first topic is health plans. Why health plans? There is a historic role here. Health plans were among the first to measure quality, at least as process measures, and act on the findings. They should be noted and commended for being pioneers in this area, and in fact, there is a healthcare quality measurement set called HEDIS, the Health Plan Employer Data and Information Set, developed by NCQA, the National Committee for Quality Assurance, which has 60 measures that are mainly healthcare process measures used to evaluate health plans and particularly health maintenance organizations. The NCQA reports, which were covered in the previous lecture, calculate lives saved based on outcomes that occur from adherence to these process measures. HEDIS has a number of categories and then specific measures within those categories. There are effectiveness of care measures, such as childhood and adult immunization, use of beta blockers after myocardial infarction, or MI, screening for various types of cancer, and a number of measures related to chronic diabetes care. There are also measures on access and availability to care, such as access to preventive health measures, how available primary care providers are, and how soon prenatal care is initiated after a woman has been diagnosed as being pregnant. There are also measures related to satisfaction with care, including member satisfaction surveys and the use of various services, such as preventive measures. These measures allow health plans to compare themselves to other health plans. What about quality reporting in the outpatient setting? In the United States, major efforts in this setting are led by the Centers for Medicare and Medicaid Services, CMS, mostly in the Medicare program. The major CMS program is the Physician Quality Reporting System, PQRS, which was formerly called PQRI. The program provides physicians participating in Medicare an extra 1% reimbursement for reporting on a large number of measures, a total of 194 in 2011. They also receive 0.5% for maintenance of certification in their medical specialty. It should be noted that the bonus changes to a penalty starting in 2015. Another CMS program is the Electronic Prescribing (ERX) Incentive Program. This program provides an additional extra 1% reimbursement for use of e-prescribing. The bonus continues through 2013. A penalty starts in 2012. The quality measures in this program are separate from meaningful use regulations, for which the Government Accountability Office, GAO 2011, has criticized CMS for inconsistencies across the programs. Some sample PQRS measures include these to measure the following conditions. For diabetes mellitus, the quality measure is the percentage of patients aged 18 to 75 years with diabetes mellitus who had most recent hemoglobin A1C greater than 9.0%. For patients undergoing resection for lung or esophageal cancer and requiring thoracic surgery, the measure is the percentage of surgical patients aged 18 years and older who had clinical TNM classification of malignant tumors staging prior to surgery. For weight assessment and counseling for children and adolescents, the quality measurement is the percentage of children aged 2 to 18 years whose weight is classified based on BMI, body mass index percentile for age and gender. There are also quality measures for inpatient settings. Much of this activity focuses on an organization, actually a collaboration of organizations, called the Hospital Quality Alliance, or HQA. The HQA includes the CMS, the Joint Commission, and others who have created a starter set of quality measures for various conditions initially focused in 4 areas. The Hospital Compare Project is a voluntary program where organizations that submit these quality measures have them published on a website so individuals can compare one hospital with another with regards to these quality measures. The HQA project actually consists of 2 programs based on reporting that is done to CMS. One part is the Inpatient Quality Reporting, IQR. This is for the HQA data in the 4 areas, and hospitals that do not participate actually have a 2% reduction in their Medicare reimbursement. There is another collection of information that does not measure process quality but patient satisfaction. This is the Hospital Consumer Assessment of Healthcare Providers, or HCAHPS, a measure of patient satisfaction that is also reported as part of the Hospital Compare project. Here are the HQA categories and some examples within them. The broad categories are MI, heart failure, pneumonia, surgical infection prevention, and children's asthma care. Within them are a variety of mainly process measures. These are the quality measures that are reported within HQA and made available on the Hospital Compare website. Among the measures for MI are actions such as aspirin at arrival to the hospital, when the diagnosis is made and discharged, and inpatient mortality. For heart failure, the provision of discharge instructions and the evaluation of the patient's left ventricular systolic function are measures. For pneumonia, the measures include time to blood cultures and antibiotics, as well as vaccinations for pneumococcus and influenza. For surgical infection prevention, the measures look at prophylactic antibiotics as well as prophylaxis for deep venous thrombosis. For childhood asthma, the measures are the need for reliever medication while hospitalized and the development of a home management plan of care document. There are some other quality initiatives in the inpatient setting that are not tied into the U.S. government and Medicare reimbursement. A long-standing ongoing project is the National Surgical Quality Improvement Program, or NSQIP. This is an effort led mainly by the American College of Surgeons to measure, risk adjust, and improve the quality of surgical care. For organizations that are academic medical centers, there is the University Health System Consortium, or UAC, which was once called the University Hospital Consortium. The focus of UAC is on quality measurements for benchmarking academic medical centers. Data is provided to UAC and reports are returned to each organization. Viewers of this training may be part of these organizations and be familiar with the green and red dots, anywhere from 1/2 to 1 or 2 of each of these, representing positive deviation or negative deviation from the standard of quality. The meaningful use rules are predicated on 5 healthcare goals for the United States. One of these goals is improving quality, safety, and efficiency with core measures for both eligible professionals, EPs, and eligible hospitals, EHs. For professionals and hospitals, one of the core measures is the reporting of clinical quality measures to the CMS or their respective states. What are the specific clinical quality measures in the meaningful use rules for eligible professionals and hospitals? Eligible professionals must report on 3 core measures. They are allowed to substitute alternative core measures if the denominator or number measured by any of the 3 core measures is 0. Then they must also report on 3 of 38 additional quality measures. Eligible hospitals must report on 15 measures. The reporting in the first year of meaningful use is by attestation of the numbers, but in 2012 and beyond, the actual quality data must be provided. CMS is aiming to align all of its quality reporting programs, PQRI, CHIPRA, or Children's Health Insurance Program Reauthorization Act, IQR, or Interquartile Range, and others, so that they are consistent and that measures required for one program are common with measures required in another. This slide shows the 3 core quality measures for eligible professionals. The first of these measures is blood pressure measurement for patients with hypertension. The second measure is assessment of tobacco use, and if it is used, whether a cessation intervention has been made. The third quality measure is adult weight screening and follow-up undertaken for patients who are overweight. Some practices, especially pediatric practices, will not be able to report on the 3 required core measures, so 3 additional core measures are allowed to be substituted in their place. One of them is weight assessment and counseling for children and adolescents. Another is influenza immunization for patients 50 years or older. A final alternative core measure is childhood immunization status for the major immunizations of childhood. There are 38 additional quality measures, of which at least 3 must be reported by the eligible professional. In these measures, the eligible professional has to report on what proportion of patients have met these measures, both the numerator of how many patients meet them and the denominator of how many patients are eligible to meet them. For example, the appropriate depression medication management method is considered in patients with depression. Other measures include breast cancer screening, cervical screening, colorectal screening, and various types of treatment for coronary artery disease. Continuing the additional quality measures for eligible professionals, there are a substantial number of measures for diabetic patients, such as how well blood pressure is under control, whether they have had a foot exam, and other aspects of treatment of diabetes. There are also a number of measures for patients with heart failure that are listed here. There are additional quality measures for other conditions, such as ischemic vascular disease, breast or colon cancer, glaucoma, and prostate cancer. Eligible hospitals must report on 15 quality measures. Like the other measures, these are vetted either by NQF, the National Qualifications Framework, or PQRI, and they vary for different conditions or parts of the hospital. This slide shows a broad range of hospital measures from emergency department throughput to stroke to venous thromboembolism. This concludes Lecture B of Quality Measurement and Improvement. This lecture has discussed many different healthcare quality measures that are used in a variety of settings, from health plans to inpatient to outpatient. Health plans most commonly have quality assessed by using the HEDIS measures of NCQA. Outpatient settings most often use measures in the PQRS program. Inpatient settings have a variety of measures, but most commonly used are those of the HQA. One of the core meaningful use criteria for eligible professionals, EPs, and eligible hospitals, EHs, is a series of quality measures.